Hello, and thank you for participating today. We are excited to present our Doctorate of Nursing Practice project titled Reducing Volume, Reducing Harm, a Safer Approach to Interscalene Blocks. Our team consists of Katie Monaghan, Megan Perrier, Kate Radcliffe-Papazian, and Kayla Wright. We would also like to acknowledge and thank our faculty chairperson, Dr. Rachel Edgerton, for her guidance and support throughout this project.
Interscalene brachial plexus blocks have long been a mainstay regional anesthesia selection for surgeries involving the shoulder and upper arm. Despite their popularity, their use is not without risk. Among the most significant and often underestimated is phrenic nerve blockade. The phrenic nerve, arising from the C3 to C5 nerve roots, runs in close proximity to the interscalene groove where local anesthetic is deposited. This close proximity makes phrenic nerve involvement almost inevitable with traditional nerve block techniques. It has been estimated that as many as 100% of patients who receive an interscalene nerve block will experience some degree of hemidiaphragmatic paralysis as a result. While this unintended side effect may go unnoticed in healthy individuals, for patients with limited pulmonary reserve, such as those with COPD, are obese, have restrictive lung disease, or other pre-existing diaphragm dysfunction, this can lead to respiratory compromise and adverse outcomes. Despite advances in technology that allow for better and more precise techniques, most facilities still choose to administer 20 to 30 milliliters of local anesthetic in an attempt to achieve adequate spread. Clinical signs of hemidiaphragmatic paralysis may include dyspnea at rest or on exertion, decreased oxygen saturation, use of accessory muscles, hypoventilation, and increased work of breathing. In severe cases, ventilatory failure requiring respiratory support may occur, ranging from the need for supplemental oxygen to prolonged intubation or reintubation scenarios. Traditional volumes of 20 to 30 milliliters were necessary for landmark-based techniques where larger coverage was needed due to less precision. But now with ultrasound guidance, we can see what we used to just guess at. This means we can provide adequate surgical anesthesia using less local anesthetic volume. With modern ultrasound, we can directly visualize the nerve roots, control our needle tip location, and watch the spread of local anesthetic in real time, allowing for effective anesthesia with as little as 5 to 10 milliliters of local anesthetic. With precision, training, and the right technique, low-volume interscalene blocks are a safe and effective alternative to traditional high-volume methods.
Today we want to share what the research shows about low-volume interscalene brachial plexus blocks. When we look at the evidence, several key findings emerge. Using lower volumes, about 5 to 10 mL, results in fewer complications. The precision of placement with ultrasound is more important than the volume used. Importantly, low volumes do not compromise block density, pain coverage, or duration. To get a clear picture, we reviewed 546 articles that populated with our key search terms and scholarly databases. From those, we selected 21 quality studies that specifically addressed interscalene blocks with low local anesthetic volumes. The breakdown included 10 randomized control trials, 5 quasi-experimental studies, 1 observational study, and 5 case studies. Collectively, these provided strong evidence to evaluate the safety and efficacy of lower volume approaches. Across these studies, the findings were consistent. There was a significant reduction in phrenic nerve paralysis when using lower volumes without compromising analgesia. Lower rates of respiratory complications and distress were reported, which also improved discharge outcomes. Both volume and placement were more impactful than the drug concentration. And importantly, patients still had adequate pain control and full coverage with no significant difference in the need for rescue pain medication postoperatively compared to higher volumes. Based on this evidence, our literature review strongly supports decreasing the volume of local anesthetic and interscalene brachial plexus blocks. Doing so significantly lowers the risk of phrenic nerve palsy and respiratory distress while maintaining effective pain control. Overall, this practice advances both patient safety and patient outcomes. So, what does this mean for clinical practice? A safer standard is clear. Utilizing ultrasound guidance can ensure precise placement. We can decrease the local anesthetic volume to less than 10 mLs to reduce respiratory compromise from phrenic nerve palsy, and optimize the location of the needle tip before injecting. In summary, our recommendation is straightforward. Use ultrasound guidance to visualize and confirm needle tip placement. Once placement is verified, administer 5 to 10 mLs of local anesthetic to achieve effective analgesia without unnecessary complications. This approach balances efficacy and safety and represents a best practice standard moving forward. This slide emphasizes the importance of precision with lower volumes during interscalene blocks. The current best standard of practice is a single injection posterior placement of local anesthetic at the C5 to C6 level. This approach minimizes phrenic nerve involvement and avoids the unnecessary risks of advancing anteriorly around the nerve roots. The video link provided here demonstrates that a single posterior injection after puncturing the brachial plexus sheath is adequate for local anesthetic spread and creating an adequate block. The local anesthetic naturally spreads circumferentially, eliminating the need for multiple injections or high volumes. The circumferential spread also helps prevent anterior spread to the phrenic nerve, further improving safety.
For an in-plane technique, the needle is positioned 1 to 2 centimeters lateral to the transducer and advanced under the transducer until the tip is just posterior to or between the C5 and C6 nerve roots. The local anesthetic is injected incrementally close to the nerve roots. The needle can be redirected if the spread of local anesthetic is not deemed adequate. It is not necessary to have local anesthetic anterior and posterior to the nerve roots. Posterior spread only of local anesthetic is effective.
In recent years, a new local anesthetic formulation was introduced to anesthesia. Exparel is a liposomal bupivacaine that has gained FDA approval for interscalene blocks. Because the bupivacaine is encapsulated in lipids, it allows for a slower release of the local anesthetic. Exparel does not diffuse rapidly from the injection site like other local anesthetics. The medication takes direct effect on the site it is placed. This is why precision in placement of Exparel is so important. I'm sure everybody remembers Randy Travis drinks cold beverages as a study mnemonic when studying the brachial plexus. The brachial plexus divides into 5 roots, C5 through T1, 3 trunks, 6 divisions, 3 cords, and 5 final branches. The sensory regions innervated by the brachial plexus include the superior aspect of the shoulder to the axilla. The phrenic nerve is not a component of the brachial plexus, but it does lie close to the brachial plexus bundle. The interscalene block aims to block a portion of the brachial plexus targeting the C5 through C7 roots. Ultrasound guidance is used to visualize landmark structures in a short axis view, introducing the needle with an in-plane approach, projecting towards the hypoechoic brachial plexus nerve roots, lying between the anterior and middle scalene muscles. For a refresher, please visit the link to the Nysora detailed overview for a quick review of the interscalene block. With lower volumes, we can increase patient safety, but hopefully also lower costs to the facilities. Cost-benefit analysis is dependent on the facility and will not be controlled within our research project. Specific cost savings are facility dependent, and they may vary by geographical location. We do offer up some potential changes for cost-benefit analysis, which include decreasing length of stay leading to decreased medical costs, also preventing negative complications from medical interventions, such as peripheral nerve blocks, can have an effect on the hospital consumer assessment of healthcare providers and system surveys and Medicare reimbursement. and the potential of splitting multi-dose vials, which would be done under a pharmacy hood, with the potential for a decreased overall amount of local anesthetic used.
Why wait? Let's do better. High-volume interscalene blocks are still used in practice and can lead to phrenic nerve blockade and respiratory compromise. With the advent of ultrasound technology, we should be able to use less local anesthetic with more precision, preventing complications. A literature review reveals that a low-volume block of 5 to 10 milliliters, administered with ultrasound guidance, decreases complications while maintaining block density, pain coverage, and block duration. As anesthesia providers, we have the ability and resources to positively impact patient care. So we ask you to consider making this important practice change. We know high-volume interscalene blocks put our patients at risk. Literature supports a low-volume, ultrasound-guided approach. We have ultrasound technology and the ability and resources to make an impactful practice change today.
Thank you so much for your time and your participation. Please don't forget to share our project with other anesthesia providers, as it will not only help our Doctorate of Nursing Practice project, but also for our future patients. Please don't forget to proceed to the post survey for your chance to be entered in the gift card drawing as well. On this following slide, you'll see the references for our project if needed. Thank you so much and have a great day.